New section this week, Lab 0, introductory lab starts this week as well, Thursday. We're moving into spirometry and respiratory physiology, so this is meant to be an introduction to the material that you will use for lab, which is next week. The specific instructions for lab are next week, and this is the foundational information, which you might remember from anatomy and physiology in second year, 2 years ago, 3 years ago, 1 year ago. It was a while ago. We're going to go through the overview of the respiratory system, factors that affect gas exchange, how they should work, so that in a compromised situation we can understand perhaps why gas exchange would be compromised or not working optimally. Thursday, we'll spend a lot of time discussing regional differences within the lung. I think a lot of your experience so far has just been with the lung as one organ, one system, one bag. But the lung is broken up into many different regions, and how those regions are supplied with blood or air can drastically affect its function. And we'll finish with the regulation of ventilation, how and why ventilation increases with exercise. Again, the highlights of A&P may be a bit of extension, but something I think that is fairly familiar. So when I discuss volumes, I usually refer to one standard volume and to compare between volumes. They're at standard temperature and pressure dry. STPD is a good way to do that because there's no confounding effects of temperature or pressure on the volume. And that's simply what Boyle's and Charles's law states. Volume is inversely proportional to pressure according to Boyle's law. So if pressure goes up, volume goes down. All else the same. If everything else stays the same, pressure can compress volume. And then Charles's law, at a standard pressure, temperature can influence the volume. So higher temperature, higher volume, according to Charles's law. Higher pressure, lower volume, according to Boyle's law. And that's why we want to standardize a lot of these terms. Although now that I take the time to describe that to you, the values that you get from the metabolic cart will be, are they at STPD or something else? Do you remember? Has it never been articulated? I really only articulated it a couple years ago for the first time. I'm like, oh, that makes a lot of sense. They're at body temperature and pressure saturated. So the opposite of STPD, but that's because we need to measure the amount of gas, the amount of air that's seen by the body. And it's seen at the lungs at body temperature and saturated completely with water. So to compare between individuals or the concepts, we use STPD, but the values you get from the metabolic cart are body temperature and pressure saturated, BTPS. It's what the lungs experience. So with that out of the way, we'll recap, in your experience, what should be common functions of the lung. And it's no surprise that the number one function of the lung is to move oxygen from the environment into the body, from the air into the blood. The complementary task is to move carbon dioxide out of the blood into the environment, a quote-unquote waste product of metabolism. These aren't the only functions of the lung, although these are the two main functions, and often our view of the functions of the lung stops here, but the lung can also metabolize some compounds. It's a site of metabolism. This might be one that you remember from A&P. The metabolism of angiotensin 1 to angiotensin 2 by angiotensin converting enzyme occurs in the lung. There's a lot of upstream and downstream activity. I've just sectioned off this portion of the schematic here. This is usually in response to a drop in blood pressure or hemorrhage or dehydration when you need to retain fluid and keep body fluids up. Angiotensin 1 is converted to angiotensin 2. And at the kidneys, that works to retain fluids, retain sodium, pull water back into the body, increase blood pressure. Really important when you're dehydrated or hemorrhaging. It's a complication for a lot of individuals with high blood pressure. That's why ACE inhibitors are a common medication for individuals with high blood pressure. You don't want to retain fluid. You don't want to reabsorb sodium. In fact, you want to excrete fluid or dispose of fluid to reduce blood pressure. So that's a crossover point. Just a point of interest, perhaps. The lungs also act to filter some unwanted material from the circulation, and they're a reservoir for blood that can be drawn upon in the case where blood is needed. Generally, though, it stays pretty intact at a very low pressure to allow circulation to continue. And we'll talk more about that when we get to the discussion of COPD and chronic heart failure a few weeks down the road. But we'll start that when we get to the next week's section. So the lungs are the first step. They're the first point of contact for oxygen in the environment as we endeavor on this long journey to deliver it to its endpoint. The mitochondria, specifically complex 4, where it's reduced to water, it's reduced at the end of the electron transport chain, and there's many different bottlenecks along the way, things that can go wrong or that need to not go wrong in order to ensure proper delivery of that oxygen. Many potential bottlenecks, and this classic diagram outlines a lot of them. There's been a lot of argument and controversy over the years as to which is the biggest bottleneck or even which area is the main limiter to VO2 max, for instance. Why do we have a maximum ability to take up and use oxygen? It has to be somewhere in this pathway, but there's still a lot of controversy as to where that is, and it might change depending on if the individual is a trained athlete or a sedentary older adult. But that's not the point of this slide. We're not going to explore that bottleneck, and there are certainly some courses that are devoted to one section at a time. Muscle metabolism will deal with the muscle metabolism section at the end, the actual site of utilization of oxygen. We're just focusing on number 1 in this section. And today we'll talk about 2 of these 4, maybe 3 of these 4 characteristics that facilitate the take-up and delivery of oxygen in the body, so that we can understand when we get to the next section where that might be compromised. So we'll outline in varying degrees of depth how and why O2 is likely to diffuse across the lungs, how ventilation acts to facilitate that diffusion. Thursday will largely be spent discussing the alveolar ventilation-perfusion ratio. And just show of hands or by general assent, is that a term that's familiar, ventilation-perfusion? You've heard of it before, maybe, maybe not. You remember it in varying degrees of certainty. Okay, we'll get into that in depth on Thursday. That's the segmenting of the lung into individual sections, which is an important next step in our understanding of the lungs as an organ. And hemoglobin O2 affinity, we actually won't talk about this a lot. It does change with temperature. It changes with pH. This is the shape of the sigmoidal loading curve. You remember from biochemistry, it shifts left and right under various circumstances to facilitate the loading or offloading of O2. While it's flexible, the range is often fixed in normal situations. So we're going to assume that this is a standard and not limiting. Our discussion will really focus on the first three. That's as much as we're going to talk about that in this section. So the likelihood that oxygen will diffuse is underpinned by Fick's Law of Diffusion. Fick's Law of Diffusion. And this is an equation that states simply diffusion through a tissue, which is exactly what we're trying to accomplish at the lung, is proportional to two things. One, the pressure difference across that membrane. Two, how much of that membrane you have access to, the surface area of that membrane. And then it's inversely proportional to the thickness of the membrane. And this should make intuitive sense. If you're trying to send something across a membrane, a thick membrane will impede the flow or the transport of that substance. If you have more opportunity to diffuse that substance, then it's more likely to diffuse. And if there's a larger driving force, it's also more likely to diffuse. What we've articulated in words is now shown here as an equation. The movement of gas is proportional to area, the surface area. It's proportional to the pressure difference. It's also proportional to something called the solubility constant, which I'll address briefly. It's a constant, so we don't have to worry about it changing. And inversely proportional to the thickness. So if we had numbers for these values, we could calculate the stimulus or the likelihood of diffusion. So the solubility constant, just in brief, is exactly what the name implies. How likely is it a gas will dissolve in a fluid? And that is just a chemical property of the gas and the fluid in question. And it's actually very low for oxygen. It's very unlikely that oxygen will diffuse and become solvent, will solubilize, is that a word? Will dissolve in fluid. It's very unlikely oxygen will dissolve in fluid. The way that our bodies have circumvented that limitation is through hemoglobin. Hemoglobin is the key factor in the blood that allows oxygen to dissolve. If it were just plasma, if it were just water, you might retain 2 to 5% of the oxygen that is normally loaded in the blood. It's incredibly low. It's much higher for CO2 than it is for O2, which has complications for divers. But that's not a focus of our course. So the solubility constant is constant. We won't focus on that. We are going to look in turn at each of these other three factors. Start with pressure. Pressure. Does anyone remember how we discuss or how we report pressure? What terms we're looking at when we describe pressure of a gas in the body or of a gas in the environment?
It's not millimeters of Hg mercury.
Exactly. Yeah, millimeters of mercury. So pressure of a gas in the environment. And we have one value that will assess pressure of all gases in the environment, the barometric pressure, which falls when storms come in and changes slightly throughout the week. But we don't care so much about the total pressure. We want the pressure of the gas in question, here oxygen, to determine whether there is a differential or a gradient that will allow it to move across a membrane. We need to know the total atmospheric pressure, but we're interested in the pressure of the constituent gases, or the partial pressure. Total pressure is the sum of all individual pressures. if you have a mix of two gases, the total pressure will be split, I'll say, evenly between those two gases if they're in a 50-50 mix. If they're in a 25 to 75% mix, then it's 1/4 to 3/4. It's proportional to the amount of gas in the total. So we need to know the total pressure, and we need to know how much of the air around us is oxygen and other stuff. And that will allow us to figure out the partial pressure. The calculation is simple. It's the fraction or the percentage times the total pressure. And it's much easier physiologically to think in terms of partial pressure. Partial pressure will give us a stepwise movement if there is a change in those values, a gradient that allows us to describe the movement of a gas, where fraction won't often change. Anyone remember the percent of oxygen in room air at sea level? Roughly 20%. That's pretty good. Yeah. I like 20.79. That's pretty close. Yeah, roughly 20, 21%. CO2, anyone else remember CO2? Higher than that or lower? Lower, close to 4. We do see 4, but not in room air. 4 is typically what you will exhale, and we'll measure that with metabolic carbon. It's a fraction of a percent, 0.03. Very, very, very small. The rest, nitrogen. Large component of the environmental air is nitrogen, which is inert. We don't do anything with it, so it moves in and out, and we don't care. Fractions generally stay the same. Around 20-21% oxygen here, around 20-21% oxygen at the top of Mount Whitney in California. Same percent oxygen. Problem with altitude is that the pressure is much different. Lower pressure, therefore lower partial pressure, therefore smaller gradient to get the oxygen that is around into your body. That's what people mean when they say low oxygen environments. Well, it's a low partial pressure of oxygen. The fraction's the same. So let's use an example. If we have atmospheric pressure at sea level, which is typically 760 millimeters of mercury, and the fraction of oxygen, oh, not 20.97, I've changed that number, 20.93 in this example. If the percent oxygen is as follows, the calculation of partial pressure is straightforward. 0.2093 times 760, or 20.93% of 760, gives us a partial pressure of 160 millimeters of mercury. Now, as we describe the movement of oxygen through the body in STPD, we need to correct this somewhat. So at sea level, here especially on a day like today, air is fully saturated with water. And so we'll often correct total atmospheric pressure to account for that vapor pressure of water. General rule is to subtract 47 millimeters of mercury for water pressure from the total. So we would do this calculation under conditions of STPD by subtracting 47 from 760, giving us 713 millimeters of mercury. The rest of the equation of the calculation follows suit, and we end up with 150 millimeters of mercury of oxygen at sea level. That is in the environment, immediately seen by the lungs upon entry to the body. A nice, easy round number to remember as the starting point of our cascade. And this should be more familiar. I think some of you were thinking 160, that sounds different than what I remember. I remember 150. Well, that's why. The correction for the saturation with water vapor is how we get to that 150 millimeters of mercury. So this is our outside pressure, or our starting pressure. And you've probably seen something like this. I hope you've seen something like this, which illustrates the cascade of pressures as oxygen travels from the air around us into the lungs, into the blood, to the tissues, and back again. Even as we enter the body, we are now molecules of oxygen. As we enter the body, there is a gradient down into the alveoli because oxygen is always being consumed and pulled out of the air in the lungs. So there's a gradient here which allows diffusion of oxygen towards the base of the lung. As the capillaries surround the alveoli with deoxygenated blood returning from the tissue, there's a gradient into the bloodstream. We've gone from 150 outside to just over 100 inside the alveoli. And now there's a stepwise gradient down to match the venous PO2 of 40 millimeters of mercury. And we know that is a fairly effective process. What we're describing today is that it's a fairly effective process. This is somewhat of a spoiler. Where there's almost full equilibration. PO2 in the outgoing arterial blood is almost exactly, very close to the alveolar PO2. And that's distributed to the tissues. It remains intact until it finds itself in the vicinity of oxygen-consuming tissues, whatever those happen to be. The PO2 in those tissues is lower, and the terminal PO2 is difficult to measure. Our best guess is that at the mitochondria, the terminal endpoint, PO2 might be in the single digits. So a fairly large gradient from the arterial blood to the endpoint within the cell. As the blood passes over the tissue, oxygen is removed and eventually consumed, but not completely. We're left with some residual oxygen on the venous side that returns back to the heart, back to the lungs, and is the start point for a new circuit. So here we're extracting about 2/3 of the oxygen we have available in this example. For you sitting at rest, writing, would that hold up? Do you think you're extracting more or less? More. I think you're extracting more than 2/3 of the oxygen from the arterial blood. Why do you think that? I'm curious.
Not completely at rest.
Not completely at rest. Okay, so that logic holds up. If you're not completely at rest, and for the further away from rest that you go, absolutely, you'll extract more. I'd probably argue that you're pretty close to rest right now.
So it wouldn't be a big change, it would be a slight change.
It wouldn't be a big change. I would say it would almost be lower. Typically 25%, 30% of the oxygen will be extracted from the arterial side sitting at rest. And if you're writing and that's not too taxing, if you're just following along, your brain can take a lot of oxygen too. So if you're thinking really hard, that might change. But you're probably extracting less than this. This is a moderate type of exercise, and at really intense exercise, you might be extracting 75–80%. So there's always still a little bit left over, just for context.
So this cascade's at moderate?
This cascade would be at moderate. Yeah, I would think this is a moderate type of exercise. And if you believe me that you only extract 75 or 80% of the oxygen from the arterial blood at heavy exercise, that suggests this is not the limitation. It's not the point of this class to figure out what the limitation is, but it suggests that it lies elsewhere, outside of the ability for the arteries to hold and deliver oxygen. But I digress. So we're fairly confident, at least according to this cartoon schematic, that diffusion, or the pressure difference, will allow diffusion of oxygen into the body. So if we go back to our Fick Law of Diffusion slide and we go through these in a stepwise manner, we've seen there's a large pressure difference. And that pressure difference carries through for each barrier or each site of movement of oxygen within the body. There is a pressure difference from outside to inside the lungs, across the lungs, from the arterial blood to the tissue. There's always a pressure difference which allows oxygen to move through the body. At the lungs specifically, our next focus is the surface area for diffusion. And you've probably seen something like this before that tries to capture the scope of the branching of the lungs from one trachea that bifurcates and divides into primary, secondary, tertiary bronchi, and then so on and so forth. We end up with just an amazing puzzle network of terminal bronchioles, alveolar sacs, and eventually alveoli at the very distal tips. A spiderweb, a meshwork of branching. What we care about is the surface area for diffusion. So you've probably seen something like this that divides the lung into two main zones. So we have the conducting zone and the respiratory zone. Somewhat familiar? The conducting zone has the job of transmitting or transporting the air to the sites of diffusion, and the respiratory zone are those sites. So there's no diffusion that occurs early on in the lungs, if you think about it as a journey. All the diffusion occurs in the respiratory bronchioles and then distal to those. Alveolar sacs and largely the alveoli. So if at each branch the lung tissue divides, there are about 10 branches or 10 divisions before the bronchioles and 15 till we get to the respiratory zone, which means if you do the math, and they're only bifurcating, so splitting in two, 2 to the 10 is 1,024 bronchioles. 2 to the 15 is 32,768 respiratory bronchioles, and then the alveoli on top of that. So 32,000 of these, and then all of these buds, the alveolar sacs with individual alveolar pouches on the ends, are distal to those. Exponential division makes for a massive surface area. And you've heard the tennis court analogy in the past. Doesn't really matter. Lots of surface area for diffusion. This articulates what we just talked about, the conducting zone versus the respiratory. No diffusion occurs here, which is fine. There's little surface area there anyways. The majority, the lion's share of the surface area for diffusion is in the respiratory zone, comprised of the respiratory bronchioles, the alveolar ducts, and the alveoli. And then that is indicated on this next slide, which is a representation of cross-sectional area. So the area of the airways through which air can move, and we see a pretty stable, consistent cross-sectional area over the first few divisions, and then an exponential increase as we enter the respiratory zone where diffusion needs to occur. Yeah.
Is that total cross-sectional area that's diffusible across?
The cross-sectional area is, if you took all of the tubes and put them together, it's the diameter, the cumulative diameter of the airways. The area that's available for diffusion is the 60 to 80 square meters, which is the surface area, the walls of that cross-sectional area. So massive opportunity for gases to move across, which means massive opportunity for oxygen to diffuse and to satisfy the Fick equation. We're not concerned with solubility constant. Again, that doesn't really change. But the thickness of the sheets might be important. Actually, the thickness doesn't really change when you're at the terminal site of diffusion either. The thickness is very small, very thin. This is a cross-section of an alveolus and the capillaries surrounding an alveolus with a red blood cell or an erythrocyte passing through. So you can see the red blood cell, the typical disc shape, torus shape, cut in half, and the alveolar wall is shown here, roughly, and the site of diffusion then is across that wall into the capillary or back out into the alveolus itself. So very thin walls, 0.3 micrometers, incredibly small, one layer of epithelium, not a barrier to diffusion of gases. Really interesting to put this into perspective when you see it zoomed in like this. The red blood cells can only go in single file. They can't go in more than one at a time, which is a large reason why blood doping causes such negative complications as you increase the hematocrit, or the percentage of red blood cells in the plasma, and they try to cluster up and force their way through these small capillaries. You end up getting more blockages than you do transport, and diffusion is inherently limited or is prevented in those cases, which can result in death with too high a hematocrit percent. So we are fairly confident all of these are satisfied. And if the Fick law of diffusion holds up, it says diffusion of a gas will occur. And so in practice, it should be no surprise that diffusion is quick. And that's all that we're showing here. We're showing successful diffusion of oxygen from the lungs into the blood. Now, I should point out, I think in the slides that you have on Moodle, this was arterial PO2, and that is true for half of this figure. But we start at the vein on the left-hand side, so I've changed it to blood PO2. I think that's a bit more accurate. Blood PO2, as we start on the venous side on the left, and then blood is transmitted through the capillaries. We end with the arterial blood on the right, and the time, the width of this graph, is the transit time through the capillaries where the red blood cell is in contact with the alveoli. The transit time represents the opportunity for diffusion into or away from that erythrocyte. And so what we're seeing is quick, full loading of oxygen in the blood. And this normal trace describes the quick, full loading of oxygen in the blood. We see a relatively low PO2 on the venous side, around 40, like we saw on our Cascade slide. That rapidly, within a quarter of a second, gets to near final PO2 levels, about 100 millimeters of mercury, and then stays that way for the duration of the time spent in the capillary at the alveoli. There isn't any additional stimulus to load oxygen because the gradient isn't really there. The gradient in the alveoli is at roughly 100 millimeters of mercury. And so after this rapid, quick diffusion, the red blood cell just continues through, happy and fully loaded. To contrast resting loading, which is shown here, we have about 3/4 of a second where the red blood cell is in contact with the alveolus. During exercise, as the heart rate increases and cardiac output increases, blood flow through the capillaries also speeds up. So if blood flow speeds up, that means transit time decreases, and in some cases, the red blood cell only has 1/4 of a second in contact with the alveoli to load itself with oxygen. Remarkably, still near full loading of O2 for that red blood cell. So the system is engineered to optimally load oxygen into the blood. We will see situations in our next section that parallel what we might call abnormal or grossly abnormal. There are chronic conditions that will limit the diffusion of oxygen, either through affecting the characteristics of the hemoglobin molecule itself, or through physical changes in the alveoli, the thickness, or the area for diffusion in the lungs that will grossly impair diffusion of oxygen into the blood. In some cases, there's no limit at rest, but exercise might be symptom limited. There would be incomplete loading of oxygen in the blood that would cause the individual to stop exercising earlier, or in grossly abnormal situations that they might have trouble breathing at rest. We'll talk about those in the next section. So we're confident O₂ diffusion is not a problem. We're not searching for the problem, but we are confident O₂ diffusion is ready and quick in this model, and so we'll turn our attention to ventilation before moving on next class to discuss alveolar ventilation-perfusion ratio. So the point of ventilation is just to renew the supply of oxygen. That's all it is. It does nothing to force oxygen into the blood. It is renewing the source of oxygen at the alveoli for Fick's law of diffusion to carry over and work. Renewing that supply of oxygen comes by renewing the air supply. Our lungs work just like bellows that expel the slightly less oxygenated air or mix it with fresh oxygenated room air and give us a new supply to maintain that gradient to transport oxygen into the blood. So ventilation occurs, it's a constitutive process, it's always happening, even without us thinking about it, although now you're probably thinking about it and laboring over the breath as it comes in and out. On average, at rest, you might breathe 500 mils per breath. Tidal volume here indicated with the subscript T, at a rate of perhaps 16 breaths per minute, but it can be as low as 10 if you're very relaxed. Maybe you're counting the breaths now. But all told, at rest, ventilation amounts to 8 liters per minute. Which doesn't mean a whole lot until you put it in the context of maximum ventilation. And this is absolute maximum. It's very difficult to get more than 200 liters per minute at very exhaustive exercise. This is in probably a large framed individual with a large thoracic cavity, big lungs, big ribs, big air moving muscles. Or the average individual might get to 140, 150, but large ventilation in the context of this resting 8 liters per minute number. And so this underpins the idea that we have the capacity to modify ventilation to renew the source of oxygen. A large capacity to do that. 22, 23-fold ability to increase ventilation. So how do we do that? Well, the constituent factors in this equation are candidates for increasing overall ventilation at the lung. But they might not increase in the way that you were expecting. We often expect, well, I would have expected before learning this years ago, for frequency and tidal volume to increase in step or in unison, almost in a linear fashion. But that's obviously not the case if you trust this Excel-drawn depiction of tidal volume versus power output on the left and frequency of breathing versus power output on the right. As the demand for oxygen increases, the ventilation increases in step to supply it. But tidal volume only increases to a point where it eventually levels off, and the opposite is true for frequency. Frequency tends to resist changes initially and then skyrockets near the end. Often during the end of a VO2 max test, your person will look like they're hyperventilating because frequency picks up so much in those late stages and high power outputs. Any idea why there's this difference or discrepancy? Let's focus on one. What about tidal volume? Why does it only increase to a point and then not increase more?
Your lungs are only so big.
Lungs are only so big. Is that what you're going to add?
Yeah, I was just going to say, like, you can get more oxygen into the body if you take more breaths, as opposed to trying to take longer breaths. It takes longer to fill those lungs up.
If you took an 8-liter breath, you'd have enough air for 1 minute, by this example. So the anatomy of the body makes your statement true. But if we weren't constrained by the thoracic cavity and the limits of the body, I'd say, well, if we could take a breath that large, we'd be fine. But the point is well taken. We don't have the capacity to take in as much air at once, and so frequency needs to accelerate to provide us with that increased renewal. Because the lungs are within a confined space, they can only inflate so much, they can only contain a finite amount of volume, and so to increase ventilation, the net amount of air moved, we need to renew that maximum volume as many times as possible in a minute. And so this spirometer, or the spirometry trace, often created with a Bell spirometer, or as we'll see in Lab 1 with the metabolic cart and a digital spirometer, is probably something you've seen before, which is a trace of the absolute volume within the lungs during normal tidal breathing, and then as you manipulate the breathing. So sitting here at rest, you're taking infrequent shallow breaths, which is represented by this middle squiggle through the center of the graph, the tidal volume. We have the ability to manipulate that, so you can take a massive inhale now and fill your lungs completely. I'm not doing that because I'm speaking, and I'm actually doing the opposite. If you take a big deep breath in, you reach a point where you can't add any more air. The maximum capacity of the lungs, the difference between that point and tidal volume, which is your resting, small, undulating volume at rest, is the inspiratory reserve. You have a complementary expiratory reserve, where if you let all the air out, you reach the, I won't say the base or the final lowest volume in the lungs. You'll reach as much volume as you can expel from the lungs, but the lungs are not empty. There's always some residual volume held over in place to maintain what I'll call inflation of the alveoli. If the alveoli are ever completely emptied, then the characteristics of their surfaces make it hard to reinflate. So we always need to maintain some pocket of air to allow new air to enter back into the alveoli. And we never tap in to this residual volume. It's difficult to measure, but we'll talk about how we can approximate it in our section next week. So because we only have this amount, this possible amount of air movement from just over 1 liter to perhaps just under 6 liters, the total capacity of the lungs, we can't reach 200 liters per minute without increasing the renewal rate of the air within that space. It also takes advantage of some elastic properties of the bone and the muscle of the thoracic cavity. If you breathe more frequently and forcefully, especially at these higher volumes, then you're not doing work to expel air as much as the muscles are returning to their normal shape and the bones are returning to the normal configuration and pushing air out. So it helps with the mechanics of breathing to be able to increase the frequency to a higher degree than the tidal volume, especially these high power outputs. The elastic recoil of the thoracic cavity will help push air out versus you having to contract the muscles of respiration to do so. It's albeit a small part of VO2, but when you're trying to perform the most work possible, you want to limit all other oxygen-consuming activities other than the working muscle to be able to sustain that high VO2 power output. So both of those things together culminate in an increased ventilation, which we see over on the right, which should technically be pretty linear, but is not, for reasons that we'll discuss at the end of this section that have to do with regulation of ventilation that you probably are already well versed with. We'll talk about the inflection point later on in this section as we get there. So this has all been review. That's a statement, but also kind of a question. I'm sure this has all been review. I think what I would like to do, I had originally planned to just leave it here, but I think what I want to do is just introduce the idea of ventilation-perfusion ratio so that we can take up an active discussion on Thursday. Ventilation-perfusion ratio. So I want to describe what I mean when I say that, but we won't jump into the regional differences right away, even though on the last slide it looked like we were. So we'll just talk about the concept, and then we will apply that concept to the regions of the lung and not the lung as a whole. Today we'll just talk about it from the level of the whole lung. So let's break this down. What does it mean to match ventilation and perfusion? Well, matching is important. The ratio describes the matching. Ventilation and perfusion are the two factors that create the ability for oxygen to be diffused. If we assume that surface area is consistent and the solubility constant is consistent, these two factors will affect the pressure gradient and therefore the likelihood of diffusion of oxygen into the blood. So ventilation-perfusion ratio. Ventilation, just like at the whole lung level, describes how much air is being renewed. If we think about one candidate alveolus, and I'll show you a nice animation in a second, which simplifies the lung to one alveolus, then the ventilation I'm referring to here is the amount of air that reaches that alveolus per minute, because we think in terms of rates. This is a constitutive ongoing process. Ventilation is the air that reaches the lung per minute, and the perfusion is similar to that concept, but from the point of view of blood. Perfusion is the amount of blood that reaches that alveolus per minute. So we're describing how much air is in contact with ideally an equal amount of blood to allow diffusion to occur. When we think about the whole body level, ventilation is VE, the rate of ventilation. Here, because we're boiling this down to one single point in one alveolus, this is V underscript A for alveolar ventilation. Alveolar ventilation is largely very similar to whole body ventilation. I'll point out where there are differences on Thursday. And perfusion, the amount of blood that reaches the alveoli per minute, is in the capillaries largely dependent on cardiac output, so the flow of blood through the vasculature. And this increases and decreases with heart rate and stroke volume. We'll see that later. Ideally, ventilation would only be enough to fully saturate the available blood. Anything more is a waste. You spent too much energy ventilating the lungs. It's not economical. And any less is insufficient. You might not have a large enough gradient to ensure proper diffusion of oxygen in and CO2 out. Ideally, you would only be able to fully or match the air. Ideally, ventilation would only be enough to fully saturate the amount of blood that's available. Why reword it when what's written there works well? So we can think of ventilation-perfusion ratios for the lung as a whole, or regions of the lung, or one single alveolus. And I'll show you an example of that here. If we boil down the lung to one point of gas exchange, I have the alveolus in the middle in blue, and then the bloodstream, the capillary, in yellow, because at this level, the plasma is yellow, the red blood cells are red. Blood gets its characteristic red color from the mass of red blood cells within, but the medium is this sickly yellow color. And if we were in the ideal situation, the amount of air would match the amount of blood at this site. So we have one red blood cell moving through the capillary for every molecule of oxygen that enters the alveolus. And if they happen at the same time, in the same amounts, we get an alveolar ventilation-perfusion ratio of about 1. Let's say in this example that a liter of blood can hold 200 mils of O2, and that there's 200 mils of O2 in sea level air. So we're trying to match the capacity to hold 200 mils of oxygen, as indicated by this red blood cell, and the delivery of 200 mils of oxygen with this O2 molecule here. I guess the point is they're in equal amounts. So for this to occur, in the ideal scenario, the red blood cell would meet the alveolus. As it's loaded with fresh oxygen, it would diffuse to and bind to hemoglobin for transport through the body. If we just do a tally at the end of this process, we're left with one red blood cell, one oxygen molecule, or 200 mils of each, for a ratio of about 1. There was just enough air to fully saturate the amount of blood that was available. Our ventilation-perfusion ratio here is 1. This is the ideal scenario. Well, you know where I'm going with this. What are the non-ideal scenarios? There's really only 2 of varying severities. You either don't have enough or you have too much air present to fully saturate the available blood. So in this example, we have red blood cells moving through the capillaries, but at a faster rate than before, a faster rate than the ideal situation. So I've had one move through for this one oxygen molecule. We tally at the end. There's an overabundance of blood. There's an undersupply of air. And so our ventilation perfusion ratio is less than 1. When we get to our discussion on regional differences, if this were ever to occur, these regions are called shunted within the body, or within the lung. So parts of the lung that have blood supply but little air supply are shunted. Of course, they're less efficient at loading or at delivering adequate oxygen to the tissues. While it may still use all of the oxygen that was delivered, it likely won't be in the amounts that are required to maintain the gradient for the rest of the body. There isn't, in practice, ever a location that will have no ventilation. It's just a relative mismatch. Yeah?
So would that occur when, like, you're talking about it normally takes 3/4 of a second for it to go through? Would this occur when it happens less than 1/4 of a second?
Would this occur when transit time is too quick? Yes, it would. It wouldn't be so much due to exercise or the acceleration of blood. It would be due to closing off of some airways in the lungs. It's mostly due to the undersupply of air, less due to the acceleration of blood. Although, as I'm saying this now, there is the opportunity to close off some capillaries in the vasculature. Your question is well taken. It is when the passing of blood is too quick. Those situations we'll get into detailed examples of on Thursday, though. Yeah, when it's too quick for the amount of oxygen present. And so the complementary example then on the other end of the spectrum is when we have an oversupply of air for an undersupply of blood. Here shown as slow-moving, sluggish blood for quick-moving oxygen molecules that continue. At the end, we have an oversupply of oxygen to less supply or a lower supply of blood with a ventilation perfusion ratio of greater than 1, higher than 1. These areas within the lungs are typically called dead space, where the delivery and transmission of air doesn't accomplish anything, where diffusion does not occur. So from a single alveolar perspective, this idea, I think, should be easy to grasp. What is less easy to grasp is that this happens for all 32,000 or more alveoli within the lungs, always. And the overall lung ventilation perfusion ratio is the sum of all of the individual alveolar ventilation perfusion ratios. The question then is how, or is whether, the ventilation perfusion ratio is uniform across the lung. Are there regions where it is above 1? Are there regions where it's below 1? Overall, is it ideal? And or why might it not be ideal? At the risk of going into anything that might be too confusing now, let's leave this for today. Okay? Does this concept make sense, though? The matching of air to blood at the site of exchange. Okay, we want it to match ideally. In practice, that is not the case, and we will discuss those cases specifically on Thursday. and finish up with regulation of ventilation at the end. It's almost exactly halfway through the lecture as well, which is good.